Good morning, and welcome to the what, who, when, where, and why of eating disorders. My name is Brandon, and if you or someone you know struggles with an eating disorder, this presentation might provide some much-needed knowledge to questions such as, what are eating disorders? Who struggles with eating disorders? When are we most susceptible to develop an eating disorder? Where can I find help with my eating disorder? And why am I facing these challenges? I hope you enjoy this presentation and find what you're looking for. God bless. The Oxford Dictionary defines an eating disorder as any of a range of psychological disorders characterized by abnormal or disturbed eating habits. Notice the definition attributes the disorder of eating to a psychological disorder. Indeed, most, if not all, eating disorders originate from mental illness, not as a result of physiological distress. However, eating disorders greatly affect the physiology of the body as they cause great destruction to body tissues, organs, and even bone density. We will discuss the dangers of eating disorders later in this presentation. What originates in the psychological domain of an individual with an eating disorder soon roots itself in physical assessment made by the individual, especially with anorexia nervosa, and less so much with binge eating disorder. At this point, you may be asking yourself, what is anorexia? What is binge eating disorder? Are there other eating disorders? Good questions. We'll start by defining and giving context to anorexia. Butcher et al. State that at the heart of anorexia nervosa is a pursuit of thinness that is relentless and involves behaviors that result in a significant low body weight. There are two types of anorexia nervosa. One, a restricting type, and two, a binge eating and purging type. The restricting type is just that, a strict restriction to caloric intake to maintain a very low weight. Patients with binge eating, purging type differ as they binge at times, indulgently consuming an amount of food that exceeds a rational amount of food, only later to purge or remove the food they consumed from their body. We will discuss purging methods shortly. After periods of binging, those diagnosed with anorexia nervosa may also compensate for the increased caloric intake by fasting or exercising excessively. Bulimia nervosa, as Butcher et al. State, is characterized by uncontrollable binge eating and efforts to purge resulting weight gain by using purging methods such as self-induced vomiting, misuse of laxatives, diuretics, and/or enemas. The difference between a person with bulimia nervosa and a person with binge eating purging type of anorexia nervosa is simply weight. By definition, the person with anorexia nervosa is slightly underweight or severely underweight, whereas this is not the case with bulimia nervosa. In fact, those with bulimia nervosa are often of normal weight or sometimes overweight. 4,800 calories is an average consumption of the binge cycle in bulimia nervosa. After such a binge, preoccupation with shame, guilt, and self-deprecation surface, influencing behaviors such as vomiting, fasting, excessive exercise, or laxative abuse, due to the breakdown of self-control. Lastly, let's discuss binge eating disorder, or BED, which has recently become a distinct clinical syndrome. Though carrying the similarity of binge eating as bulimia nervosa, BED differs in that compensationary behavior such as purging does not exist. BED is associated with being overweight or even obese, though these individuals recognize the importance of weight and shape more so than overweight or obese individuals who do not have BED. This eating disorder is most common form of all three eating disorders, affecting 3% of individuals in the United States. Who primarily struggles with eating disorders? I'm glad you asked. According to Butcher, Hooley, Minica, and Knock from the 2017 text Abnormal Psychology, both men and women struggle with eating disorders. It has been found through research that women are 3 times more likely to develop an eating disorder than men, but neither sex is immune to these disorders. When are eating disorders most likely to surface? Anorexia is most likely to develop in the late teen years, with 16 to 20-year-olds being most susceptible. For bulimia, the age group most at risk is slightly older, beginning in the early 20s, with 21 to 24-year-olds being at the greatest risk. Most individuals with binge eating disorders are older, affecting 30 to 50-year-olds at the highest rates. Where are eating disorders most recognized? Eating disorders are global. Though most research has been done in the United States and Europe, significant data has been collected from countries across the globe. These regions include, but are not limited to, Japan, Hong Kong, Taiwan, Singapore, Korea, India, Iran, China, and the whole continent of Africa. They all show prevalence of eating disorders. Why? Why do people develop eating disorders? Though a single cause of eating disorders has not been identified, genetic and environmental factors are certainly contributing factors. Cultural attitudes that emphasize thinness are significant to the development of eating disorders. Genes render some people more susceptible to environmental pressures and hence develop problematic eating attitudes and behaviors. With all mental illness, the DSM-5 is used to diagnose specific disorders, and this is the case with these eating disorders. The criteria for anorexia nervosa are restriction of energy intake relative to requirements leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as weight that is less than minimally normal, or for children and adolescents, less than that minimally expected. Intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though at a significantly low weight, and disturbance in the way in which one's body weight or shape is experienced, undue influence of body weight or shape on self-evaluation, or persistent lack of recognition of the seriousness of the current low body weight. The criteria for bulimia nervosa are a recurrent episode of binge eating. An episode of binge eating is characterized by both of the following. 1. Eating in a discrete amount of time within a 2-hour period, an amount of food that is definitely larger than what most individuals would eat in a similar period of time under similar circumstances. And 2. A sense of lack of control over eating during an episode. Also, recurrent, inappropriate compensatory behavior in order to prevent weight gain, such as self-induced vomiting, misuse of laxatives, diuretics, or medications, fasting, or excessive exercise. Also, the binge eating and the inappropriate compensatory behaviors both occur on average at least once a week for a 3-month period of time. Also, self-evaluation is unduly influenced by body shape and weight. And lastly, the disturbance does not occur excessively during episodes of anorexia nervosa. Lastly, the criteria for binge eating disorder are recurrent episodes of binge eating. An episode of binge eating is characterized by both of the following: eating in a discrete period of time, usually within a 2-hour period, amount of food that is definitely larger than what most people would eat in a similar period of time under similar circumstances, and a sense of lack of control over eating during the episode. Example, a feeling that one cannot stop eating or control what or how much one is eating. Also, the binge eating episodes are associated with 3 or more of the following: eating much more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of feelings embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty afterward. Also, marked distress regarding binge eating is present. The binge eating occurs on average at least once a week for 3 months, and the binge eating is not associated with the recurrent use of inappropriate compensatory behavior as in bulimia nervosa, and does not occur excessively during the course of bulimia nervosa or anorexia nervosa. Because of the significant destruction that the body endures due to an eating disorder, it is imperative that an individual who suffers from one of these disorders gets appropriate help. Damage to the individual consists of, but is not limited to, early death, malnutrition resulting in hair loss, skin discoloration, and dry skin that begins to grow lanugo, which is downy hair on the face, neck, arms, back, and legs. Due to poor temperature regulation, hands and feet are often cold to the touch and have a purplish blue tinge. Chronically low blood pressure results in fatigue, weakness, dizzy spells, and a sense of faintness or lightheaded feelings. Heart arrhythmias can develop due to low electrolyte intake. Laxative abuse can lead to dehydration, kidney disease, and damage to bowels and gastrointestinal tracts. Repetitive vomiting results in damage to the esophagus, the throat, and teeth, as the acidity of bile is extremely hazardous to these tissues. Medications, family therapy, and cognitive behavioral therapy, CBT, are the most effective treatments for all three disorders. Medication. Antidepressants have been used in treatment of anorexia nervosa, though effectiveness has not been found. In treatment for bulimia nervosa, however, antidepressants have been found to help, but speculation grows that the help found is more related to the mood disorders than that are associated with bulimia nervosa. Due to comorbidity between binge eating disorder and depression, antidepressants have been found to be effective. Antipsychotic medications, such as olanzapine, have found effective as they help with distorted beliefs regarding body shape and size. A positive side effect of this drug is weight gain, which in rare examples such as this is found as a positive side effect. Appetite suppressants and anticonvulsant medications have been known to help offset undesirable behaviors associated with BED. Therapy options. Cognitive behavioral therapy has been found quite effective in treating anorexia nervosa, bulimia nervosa, and BED. Family therapy has been found to be the most effective therapy option for anorexia nervosa in adolescents and teens, while CBT is the most effective treatment for bulimia nervosa. Interpersonal psychotherapy is also a treatment option that is suitable for those with BED. Thank you again for your time. I hope you enjoyed this presentation. If you have any questions or comments, feel free to email me at bdraper@warnerpacific.edu. And I leave you with this quote from Dr. Martin Luther King Jr. If you can't fly, then run. If you can't run, then walk. If you can't walk, then crawl. But whatever you do, you have to keep moving. Thanks again, and God bless.